It's my pleasure to share the virtual stage with Dr. Bradley Grant. Bradley, go ahead and introduce yourself.
Pleasure to be here, and thank you for the introduction, Dr. Lighthizer. I am in private practice. I'm in central Illinois, but we have a few locations across Illinois and Wisconsin. My primary practice location is in an OD-MD setting, and so we have a high medical practice, a large glaucoma base, a large diabetic patient base. We acquired the RETeval technology almost 2 years ago. It was June of 2023, and we have it now at 5 different locations. And so just like Dr. Lighthizer mentioned, we're performing this test on all diabetic patients. We use it for macular conditions. We also use it for glaucoma suspects and optic nerve pathology. So we really have a variety of uses for it. And to date, I think we've done around 2,000 tests in a couple years. So really integrated it in a high volume way, and have been thrilled with the clinical data that it provides for our patients, and feel like it really elevates our level of care.
Awesome. That's great to hear, Bradley. And 2,000 of that's just a tremendous. So he's a super user of the RETeval and the ERG, and that's just great to hear as we know more and more. And we'll talk about some of the exciting data from the AA, American Academy of Ophthalmology preferred practice patterns here in just a little bit. So I always like to poll the audience, and we're just going to ask one question at the start here, but I want you guys to scan that QR code. Grab your phone, and scan that QR code. And that's going to open up my Poll Everywhere page. And again, very quickly, you can open that up. You don't have to sign up for anything. You don't have to download anything. But it's going to ask you a quick question here at the start in terms of structure and functional testing. So again, scan the QR code. That will take you to my Poll Everywhere page. If it asks you to download something, just hit skip for now. Skip for now. It will bring up one question. All you gotta do is hit the button, and it will automatically register your response. This is completely anonymous. Nobody will know what you put. I won't even know what you put. Again, it's completely anonymous, but just a fun way to kind of interact and see some dialogue back and forth. You do not have to do this. You can skip this, but just kind of a fun way to poll the audience. And my first question is always this one. Do you think testing structure and function in our ocular pathology patients is important? Patients that have diabetes and diabetic retinopathy and glaucoma and those maculopathies that Dr. Grant talked about as well. All these different ocular pathologies that we see on a day in and day out, week in and week out basis. Is testing structure and function important? I've asked this question dozens and dozens and dozens and dozens of times now. I will tell you the answer is almost always 100. You guys believe in structure and function, and it gives you the best possible picture of what's going on, the most thorough, complete picture. You wouldn't want to go to a cardiologist without having an EKG. If you wanted to know your full cardiac status, they're probably going to do an echocardiogram. They may do an angiography, but you wouldn't want to have a full, complete cardiac workup without having an EKG, looking at structure and looking at function. And the same thing is true for so many conditions in the ocular space as well. So again, you guys believe in it, and I know Bradley and myself, we believe in it as well. So structure and function in ocular disease. You guys do this so well. We do this so well. Dr. Grant, I'm sure you guys have fundus photography in your practice and have had it for quite some time. Do you not?
Absolutely. Yeah. And always make sure that we're showing the images to the patient so that we can demonstrate, structure to them as well.
Yeah, and you take a look, and it's a great patient education tool. You can show them whether they have a clean retina, like on the left picture, or we've got signs of diabetic retinopathy on the right picture. But this looks at structure. If I were going to talk with you guys and say, all right, everybody on the call, what are the most common ancillary tests that you guys do in diabetes and diabetic retinopathy? 3 most common things that you do, and I bet you guys would say maybe a DFE. You're going to take a wide field photo or some sort of photograph, and you're going to do one of these as well, which is an OCT technology. And we'll come back to this in just a second. My point is this: DFE, structure. Fundus photos, let's go back here, structure. And OCT looks at structure. If you're doing a DFE and taking a photo and looking at OCT, you're missing half of the picture. You're only looking at the structural tests, and you are not looking at function. So you want to look at both structure and function. You are not going to hear Dr. Grant and myself say tonight that ERG is going to replace this. It's not. It's not. Is it going to replace the OCT? No. Those look at structure and the ERG looks at function, and they pair beautifully together to give you the most complete, thorough picture of structure and function from a retinal perspective. So still take your fundus photos, still do your OCTs. And the point of this slide is how OCT technology has evolved tremendously over the last 25 years, from time domain OCT with the Stratus OCT to spectral domain OCT, and the resolution has got better and better, and the scan acquisition time has gotten better and better over the years, and the ERG technology has done the exact same thing. It has evolved over time. We'll talk more about that in just a second. So OCT, structure, it's a must. When I poll the audience, optometry now is saying between about 75 and 90% of optometrists have an OCT in your practice. Keep doing your OCTs. Keep doing them. It's amazing technology there. And again, helps you to show, do we have a normal macula on the left? Do we have diabetic macular edema on the right? Again, amazing test, OCT, looking at structure. But functionally, we do have other options, and you guys do other options functionally. We've got visual acuity. That's subjective. It relies on the patient. We have contrast sensitivity. That's subjective, and it relies on the patient. And we usually aren't doing that in the vast majority of our patients. How about color contrast testing? Certainly, you could consider that. That is also subjective. Visual field testing. I bet every one of you has a visual field in your office. Again, you all know that is also subjective. It gives you great information about function, but it relies on the patient. Have any of you ever done a visual field before? And you regretted doing the visual field once you got the results back, and you went, what do I do with this? I've got defects. Now do I have to go dive into what's causing these scattered defects? Visual field testing is, again, subjective. Amsler grid.
Was that question ever or today?
That's funny. That's funny, Dr. Grant. We've all looked at that before, haven't we? Went, golly, patients struggle with visual fields. There's a learning curve, and you scratch your head going, I don't know what to do with this. Sounds like you had one of those today, huh, Dr. Grant?
Yeah. Yes. Doesn't make sense. Structure and function don't always match up, and we're gonna have a case about that as well. But real life examples for all of us.
Yep. Preferential hyperacuity perimetry, again, that is subjective. Dark adaptation testing is subjective. And lastly, ERG is objective. So think of this as our objective functional test. This does not rely on the patient to click a button, to read a line on the acuity chart, or do anything else. It is objective. As long as they can sit there with their eyes open and allowing you to flash a light in their eyes, that's all that is needed for this objective functional test. So, I always joke, Dr. Grant, what do you think of when you think of electrophysiology? Do you remember, guys, that room in the back at school? It was dark back there, wasn't it? You didn't want to go back there because there was wires everywhere. And you didn't want, who knows if you wandered back there, whether these wires would start to be attached to you and your nose and your head and, all this great stuff. Historically speaking, when you think of electrodiagnostics, electrophysiology, haven't we thought of, that's optometry school. That's the research center. Maybe that's a tertiary care retinal practice. Maybe big institution in Dallas, Salt Lake, Chicago, something like that. Electrophysiology didn't enter private practice. 15 years ago, Dr. Grant wouldn't have been saying, we have one of these at each of our 5 locations. That just wasn't the case even 15, 20 years ago. Here's a picture I got off the internet. This is from like 40 years ago. You're reading minds maybe as well. Electrodiagnostics is completely different than what you may remember in optometry school 15, 20, 25. Heck, even 10 years ago, it is different because of the technology that we now have handheld. Dr. Grant, any comments on that? How ERG has certainly evolved. What do you remember from school?
So, I'm dating myself a little bit. I graduated optometry school in 2007, but I'll tell you, as recent as 5 years ago, I would have used the term ERG synonymous with flux capacitor, just kind of a mythical thing that required a lot of complex wires. So, just remember that it was incredibly complex and really so complex to the point to where I don't know that we ever accurately got one. Like everything had to add up right in terms of setup and data and just, kind of an out there type of test.
I love the Back to the Future reference. That's awesome. And as long as you get up to 88 miles an hour, if that flux capacitor, it's going to take you
That's right.
somewhere
Yeah.
fun, right?
That's right.
You know, when I took over as our chief of electrodiagnostic in 2010, I graduated in 2009, finished my residency in 2010, and took over our electrodiagnostics department. And I have seen this technology evolve and evolve and evolve in the last 15 years. Where it used to be that you had these great big sensors that you had to put right on the ocular surface. And so the electrodes were more invasive. The testing took longer. We had to dark adapt patients. And we still occasionally do for some more thorough, I shouldn't say thorough is not the right word, but like when we're trying to separate the rods and cones and rod cone dystrophies and retinitis pigmentosa, you can choose to do that as well. But for every patient 15 years ago, we would sit them in the dark and dark adapt them, both eyes patched, and sit there for 30 minutes, 40 minutes. Just that's not private practice. That's not electrodiagnostics that it is today. Now we have a handheld device. We actually take this device right to the patient when we're in diabetic clinic, when we're in electrodiagnostics clinic, and they love that. They love that you can bring this right to them. And I introduce this as the EKG at the back of the eye. And I always tell them, Mrs. Jones, Mr. Jones, you ever had an EKG before? You know what an EKG is? And it's amazing how every patient, whether they've had one or not, they know what an EKG is. Everybody knows what an EKG is. This is the EKG for the back of the eye. We're going to put some electrodes right on your lower eyelids, right here, not on your eyeball, right on your lower eyelids. And we're going to flash some lights in your eyes for about a minute or so. And it's going to tell us how's your retina functioning, how's your retina firing, basically how's your retina working. Just like when they put electrodes on your chest and you had an EKG, it tells you how's your ticker working, how's the heart working, how's the heart functioning. And that's part of a complete cardiac workup. This is part of a complete retinal picture. Dr. Grant, I have been so amazed that when you bring this to the patient and you tell them that, they're just like, wow, this doctor knows what they're doing and they are going to really care for me. Have you had a similar experience?
Yeah, I couldn't agree with that more. And I set it up the same way in terms of using the reference the EKG, because everybody knows that term. But I make sure to say that we're measuring the speed and the strength of the retinal response to light. And I think that they can identify with those terms, and then even go a step further and say, and if there's a problem, a lot of times we're going to see that signal weaken or slow down. And the way that the displays, which we'll get into in a minute, are laid out, I think it's really easy to touch on those two terms, which they understand, speed and strength. And yeah, when they see, well, first, I think they're just amazed that there's that much detail to the eyeball to begin with, right?
Yep.
And the fact that we have that technology, that I've never had anyone say, yeah, we had this. Have you had it done? Yeah, we had it done 2 years ago at XYZ, right? Every time we do it, it's a differentiator for our clinic, for the care that we provide. And I'm in private practice, so from a practice building standpoint, it's never a bad thing when the patients leave their office and say, I had care that I've never had before, right?
Yep.
There's certainly value in that.
Yeah, that leaves them with a good feeling there. And we talked about the accessibility. We talked about easy to integrate. When you walk in, you clean their eyelids very quickly, put on the electrodes, clip the device right to the electrodes, and do this right eye and then the left eye. Again, about a minute, depends on the protocol that you do. And that's a key thing here. Let's not skip over this multiple protocols. Back in the day, you ran a flash ERG, excuse me, and we had to put our own cursors on the A wave and the B wave and the photopic negative response. And there was no normative database. There was no reference database, and that's, I don't want to have to do that. I don't want to have to measure how big is it from the hump of the A wave to the hump of the B wave. That's not practical. Now we have protocols that say, if you have a glaucoma patient, run the photopic negative response protocol, the PHNR. If you have a diabetic retinopathy patient, run the diabetic retinopathy protocol, the DR protocol, which gives you the DR score. If you have other retina stuff, run the Flickr 16. So we have these protocols that lay it out for you going, if I have this, I should do this test. If I have that condition, I should do that test. These protocols are just wonderful to make it easy. In my busy day, I need a macular OCT and I need a DR RETeval flash ERG. You tell your staff that and they can get it done very, very quickly there. So again, Dr. Grant's going to be able to offer multiple perspectives on this. Does the technology do something or other technology doesn't? The answer is yes. This is objective functional data. We've got structure. Wonderful. We've got fundus photos. We've got OCTs. We even have function. We've got visual fields. But I bet most of you aren't doing visual fields in your diabetic and diabetic retinopathy patients. And even if you are, that is subjective. That's looking at function. This is objectively telling us about function. It gives us something that we are not already utilizing, that we're not already using. Does it provide clinical information? Absolutely. We're going to go through that in just a second. What does this mean? If I have a normal ERG versus an abnormal ERG, what does this mean and how does that change something? Dr. Grant, tell us about incorporating this into a private practice office, space, patient flow, staff. Tell us about that.
So with any technology, if you're trying to integrate it into your day-to-day, and I think most pushback comes from just, any test that takes longer than 4 seconds, I think we can all make an excuse to how it can't fit into our busy schedules. So I think it takes a lot of legwork on the part of educating the staff on automatic protocols. And so the way that we have it situated in our office is that Dr. Lighthizer mentioned, there's different protocols for different conditions. Our staff know that if a patient is diabetic or has any diabetic diagnosis in the chart, they're getting it done, right? They're not asking me if they need it. They're not asking for the test. They're having it done before I come into the exam room. If they have macular pathologies or other nonspecific, they're getting a Flickr 16. And glaucoma suspect is a little bit more tricky just based on diagnoses. But your bread and butters in terms of your automatic protocols of your diabetic patients or retinal vascular pathologies. From a flow standpoint, we have it performed in the room, right? So again, a lot of us have space concerns because we have OCTs, we have visual fields, we have fundus, photography, and all of that takes up, a larger footprint than this does. And so just so we don't have another reason why, technician A is waiting on the visual field room because we also do ERGs in there. We do all of the other ancillary testing first. And then the last thing they do before they see the doctor, before they're dilated for a diabetic patient, is that staff will bring this test into the exam room, perform it on the patient in the exam room, take the instrument out to a laptop that we have dedicated for this test, dock it, upload it into the EHR, and there you go. So the portability is huge. Time-wise, it's faster than a visual field in most cases. And again, anytime you integrate a technology of this level, there's going to be some legwork that's required. But when you establish those protocols that just let your staff know that we're going to be running it because we need this information to make better clinical decisions for these types of patients. I was surprised on how quickly we were able to integrate this as an automatic test. And that's across multiple locations. And as we all know, every location has a little bit different personality. So 5 locations mathematically is 72 personalities. Maybe I'm exaggerating.
Yeah. Great perspective. Is this standard of care or leading edge? I would have said 2 years ago that this would have put you on the cutting edge, the leading edge. But when you have things like this, and this is the American Academy of Ophthalmology diabetic retinopathy preferred practice patterns. This is hot off the presses, docs. It's published in February of 2025, and ERG is now mentioned in the diabetic retinopathy preferred practice patterns. Certainly fundus photos and certainly OCT and all those tests, but ERG is now in there for the first time. So, this is becoming, and it's swinging more towards standard of care, which is a wonderful thing. They review articles on ERG. It detects dysfunction in patients with early diabetes. Before your patient has a myocardial infarction, a heart attack, their EKG is probably going to show some abnormalities. And before they have a massive retina attack in diabetic retinopathy, hemorrhages, proliferation, they're going to have an abnormal ERG as well. So I just, I thought this fit well into this. Is this leading edge? Is it standard of care? It is swinging more and more and more towards standard of care. So I think it's wonderful that the American Academy of Ophthalmology now included the handheld ERG, the RETeval, in its preferred practice pattern. So it's started leading edge, and it is swinging more and more towards standard of care. Patient friendly, we've described that already. And lastly, Dr. Grant, will it be profitable and or practice building Again, I'm in academia, so I'm going to kick this to you on the efficiency, billable, referrals, profit building, practice building.
All of the above. Anything that's a billable CPT code that is a necessary test based on standard of care is something that's going to build profit into the practice. You can look up the CPT code 92273. Average reimbursement for us, I want to say, is somewhere around 110 to 130 per test, depending upon the payer. And the ease of which now, because it's becoming more commonplace and because it is now seen as a standard of care, then we're seeing a lot of payers adopt multiple ICD-10 codes, and it never was too much of a problem, but we're seeing it getting better and better. So all of your standard diabetic retinopathy codes, hypertensive retinopathy codes, retinal hemorrhage, venous engorgement, microaneurysms, all of those retinal vascular type codes, optic nerve pathologies, optic atrophy, macular pathologies, all of those are billable ICD-10 codes for the test. We talked about how there's different protocols in terms of the ARCH test, the Flickr 16, all of them have the same CPT code. So you can use a variety of different ICD-10s for this. And again, first year, I think we had maybe a handful of payers that we had trouble recognizing the 92273, but really has not been, except for the one-offs that you get looking at EOBs, but for the most part, it's been just as easy to be reimbursed as it would be for a nerve OCT for a primary open-angle glaucoma patient.
ERG tests the overall retina, the flash ERG. That's an electroretinogram. It tests the outer retina, and you can go into A waves and B waves and all that stuff, photoreceptors and bipolars, but we're not going to dive into the weeds because we don't have to anymore because we have these protocols. It tests overall retinal function from top to bottom, left to right, nasal, temporal, superior, inferior. It's a global test. How is the retina doing? Now, there's other protocols, as Dr. Grant said, that can look at maculopathies, things like that. But our DR protocol is going to be a global test of overall, how's the retina doing? How's the retina functioning, again, for the totality of that retina? Visual acuity. All of you test visual acuity in your patients, and it looks at the central 2 to 3 degrees. Visual acuity is not a great indicator of how your diabetic patient is functioning. They could have non-foveal involving diabetic macular edema, moderate NPDR, severe NPDR, and yet their visual acuity could be relatively good. Yes, you have to do it for standard of care, but it's not the best indicator of how your diabetic is functioning. OCT, structure, awesome. Got to do OCTs. There's your 24-2 or your pattern ERG, which we're not going to talk about tonight. Again, looking more at that central function. It's subjective, and that's what the full field, the flash ERG looks like. Again, superior, inferior, nasal, temporal, central, peripheral, mid-peripheral. That's what this looks like, the totality of that retinal response. How is the retina doing? So, and here's your codes, and your code is 92273, as Dr. Grant said. And here's your most common protocols. These are the 3 most common protocols. The beauty of this device, for an electrodiagnostic nerd like myself, when I first had my hands on this, that was, probably 4, 5, 6 years ago when we first had it. Then we got it back in our practice 2 years ago. You can dive into the electrodiagnostic weeds if you want to. You can do that step by step by step by step. It's called an ICEV protocol on rods and cones and retinitis pigmentosa. You've all got it in there. Now, you're probably not going to go to it very often because these are the most common protocols that you're going to use. Number 1 is your diabetic retinopathy assessment protocol, your DR protocol. Number 2 or number 3, you could flip those depending on your practice, whether it's glaucoma heavy, then it's going to be the photopic negative response, optic neuropathies, or it's retina heavy, non-diabetic. That's your Flickr 16 there. So those are your 3 most common protocols. We're going to have cases to highlight 2 of the 3 tonight. So how do you interpret these? You go ERG. Gail, is it still blurry? Can we even see this?
I can see it fairly well. I can see it pretty well.
Okay. So, don't get overwhelmed by how to interpret an ERG. Dr. Grant said it beautifully: speed and strength. How quick is the retinal response and how strong is the retinal response, okay? And this is very similar to EKGs. Dr. Grant is not a cardiologist. He's not a cardiac specialist. I'm not a cardiologist or a cardiac specialist, and neither are you. But we can all probably look at this and go, that looks like kind of a normal EKG. You know, that looks pretty good because the speed and especially the strength are showing on this what looks to be fairly normal EKG. And even though none of us are cardiologists, I'm guessing all of us recognize that that is not a normal EKG, right? The speed and the strength are gone. Obviously, this is flatlined, an EKG, incredibly abnormal. But notice the difference in the strength, which is the height of the peaks. And there are no peaks here at all. So the strength is gone in this patient where the heart is not functioning at all. The same thing is true with these ERGs. And we're looking down here at the bottom for the right eye and the left eye, the strength and the speed. You want your ERGs like you want your athletes. And you want your athletes strong and quick. Strong and quick. You want your ERGs strong and quick. And the strength is the height of these peaks. Again, we're talking qualitative here, just looking at these peaks. There's no numbers yet. We're going to get to the numbers in just a second, but I'm looking at these peaks, and are they nice and strong? The bigger the peak, the better. That's the strength. The speed, are the peaks happening when they should happen, or are they slower than they should be? The software actually gives you a little cheat mechanism. See this little rectangle right here? It's saying this is where that first peak should land. And if it's below this little rectangle, that means it's low, which was weak. And if it's behind the rectangle, that means it's slow. It's not happening as quick as possible. This is a very, very, very normal, very normal ERG. Okay, let's compare and look at abnormal. Okay, notice the difference here. Okay, now it's not flatlined like the EKG above it, but notice how the peaks, instead of looking like this, where they're nice and strong and they're nice and quick, they now look like that. And these are both low and slow. They are low and slow. This is an abnormal retinal response. This retina is struggling. This retina is struggling. Okay, it's low and it's slow, and we'll get into the numbers here in just a second. So that was, again, actually a Flickr 16 protocol. Here's the DR protocol, the number one protocol that Dr. Grant and I utilize, and it gives you, the first thing I look at is the DR score. The DR score, the higher the number, the worse it is. The lower the number, the better. This is like your golf game. The lower the number, the better, and the cutoff is 23.4. 23.4 and lower is normal. 23.5 and higher is abnormal. And really, I break that down even more. If it's in the teens, I consider that normal. If it's kind of 20 to 23, that's borderline. Still normal. It's low normal, borderline. And 23.5 and higher, that is abnormal. And you get above 26, and that's really abnormal. The retina is having an impending attack going on, which we'll talk more about in just a second. So first thing I look at is the DR score. The lower the number, the better. In the teens, love it. 23.5 and above, that is abnormal. Then I dive down and look at your qualitative. Again, there's your peaks. Okay, look, there's the peaks there. But then let's go into the numbers. Okay. We all like numbers. Give me numbers, okay? And we have right eye and left eye. Again, right eye and left eye. And we have, I love that it gives you percentages. The first one is the time. Milliseconds, that's time. How quick did this right eye response happen? It actually does two tests in the right eye over the course of about a minute. And that's why you have the 16 and the 32, two different brightnesses. But I'm looking at in it with a time. Dr. Grant, if you are running a 100-yard dash, do you want a big number or do you want a small number in a 100-yard dash? What's the answer?
So we're talking about what I want, not what I get, right? What I want
you
is a
want.
low number.
You want a low number in a 100-yard dash.
We'll go low. Yes.
We'll go low. So my point is this. Can you guys see my cursor, Dr. Grant, wiggling here?
Yes, we can.
So for this in the right eye and this in the left eye, the lower the percentage, the better. This is the quickness, the speed. The lower the percentage, the better. Okay. Again, these are both very, very normal. For the strength, this is the strength in the right eye and the strength in the left eye. If you enter a weightlifting competition, strength, do you want a big number or do you want a small number? In a weightlifting competition, now you want a big number. So for this one, the strength of the retinal response, the bigger the percentage, the better. The bigger the percentage, the better. And you can tell when you look qualitatively at these two waveforms, right eye and left eye, which one doesn't quite look as strong. The left eye, the peaks are not quite as strong as the right eye, and the numbers match up. There's the right eye strength, about 50%. That's right in the middle of the normal range. And this one, even though it's still in the normal range, it's on the low end of normal. Again, the bigger the number, the better. The lower the number, the worse there. So there's normal. Can't know what abnormal is until you know what normal is. Here's abnormal. This is a patient of mine. You take a look at this, and I start immediately with the number. The DR score is elevated, 24.8. And you take a look at the qualitative data. Is this more low or is this more slow? Is it more low or is it more slow? Are those peaks lower than they should be, or are those peaks occurring after where they should land, which is in those rectangles? This is more more slow than it is low, which indicates cellular dysfunction. Dr. Grant, any pearls that you have when you interpret these DR scores?
No, I start right at the top with that number. I think that patients, again, you'll hear me compare this to glaucoma management so many times, because I think patients, just like they really cling to their IOP, right? They want to know what their number is when you're seeing them so often. In the same way, the DR score gives that kind of influencing factor to the patient. They want to know what that score is. Is it better? Is it worse? How am I doing? Again, the one thing on the bottom there, the last piece of the DR protocol, is also watching the pupil. So when we do this test on diabetic individuals, we do not dilate them prior to the test, because in diabetic stress, we know that there is attenuation of the pupillary response, right? The difference between photopic and scotopic diameter of the pupil is altered. And so you can actually see on Dr. Lighthizer's examples there at the bottom, the difference between the scotopic and photopic pupillary size is reduced in the individual with diabetic retinopathy. And so it's another piece that I look at just to confirm some of those measurements.
Yep. Undilated tests, and this number that it comes from the strength, the speed, the age of the patient, and that pupillary response that Dr. Grant mentioned as well. So what does this do? It helps you to detect, helps you to predict, follow, and monitor. So how does this change anything? If this is your patient tomorrow or next week, and this patient has, let's say, mild NPDR or moderate NPDR, or maybe they've got some vision changes, how does this change anything? Okay, we've got an abnormal DR score, 24.8. This patient, his retina is stressed. And what does this mean? It means that they are more likely to progress quicker through the stages of diabetes and diabetic retinopathy. So what would this change? I would see this patient back more closely. Instead of seeing a mild NPDR back in a year, maybe you see them back in 6 months. Or if you were going to see them back in 6 months, maybe you see them in 4 months. So change the follow-up schedule. Maybe you do an OCT angiogram. Maybe you do a visual field. You do more ancillary testing. You repeat your OCT and photos more often. Better patient education. You're going, all right, Mrs. Jones, we need to get this A1C that's 8.2. It's affecting the ERG, and we are seeing stress. If I told you your EKG was abnormal, that would concern you. I'm telling you your ERG is abnormal, and this is telling us we're going down a road that you and I don't want you on. And at the end of that road could be vision loss. So you change the follow-up schedule. Maybe you do additional testing, better patient education. I'm a big fan of nutritional supplementation in our patients with diabetes and diabetic retinopathy. So it allows you to do a lot of things, from predicting who's more likely to progress, who's more likely to stay stable, how do I follow them, and then monitor them over time. They improve their A1C. They're on nutritional supplementation. They got diet and exercise, and now we can follow that number over time that Dr. Grant mentioned and see, is it getting worse? Is it getting better? Which we've seen in some cases, which I'll highlight that in just a second there. So let's get through a couple of cases here in our last 10 minutes before we take on questions. 77-year-old male, type 2 diabetic for 19 years. Again, A1C 8.2, which is not out of line with the patients that I've seen. This is a patient of mine, vision 20/20 minus 20/30 plus. He said, my left eye is just not quite as good as the right eye. It's been that way for quite some time. Not terrible, but he goes, I just wish my vision, my left eye was just a little bit better. Again, long-standing type 2 diabetic, 19 years. There's the back of each eye. You take a look here. And again, this is a picture of mild NPDR. Mild, you can see we've got a couple of small microaneurysms scattered here and there, nothing major, no exudates, no venous beating, no cotton wool spots, no, frank hemorrhages or anything like that. We got mild NPDR here. Again, overall looks pretty good. Macula looks pretty good in this 19-year diabetic with an A1C of 8.2. OCT in the right eye. OCT in the left eye, and ERG. So again, based on this, OCT, this is a 20/20 macula. Looks great. This doesn't trigger any, bells or alarms at all, but the ERG. And you take a look at the ERG, and again, that's why I went through that. Less than 20, if it's in the teens, normal. Kind of 20 to 23, I'm going to interpret this. It's borderline low normal, not crazy abnormal, but I'm going to look at it closely. And then if it's above 23.5, that's abnormal. Above 26 is very, very abnormal. So right away you look on, all right, 21.6, that's in the normal range, even though it's low normal. But you dive down into the waveforms and you go, all right, even though it's overall looks pretty good in terms of the overall number, we are a little bit low and a little bit slow for both the right eye and the left eye. For the speed, I want low percentages, and I want low percentages, and we're darn high on these percentages. Again, right on that border of 2 standard deviations outside the normal limits. You can see it's flagging in the left eye. All right, how about the strength? I want big numbers for the strength, the weightlifting competition. I want big numbers. And again, they're both green, but they're low end of normal. So again, I look at this and I went, we could get this better than it is. And based on that, he's a longstanding diabetic, A1C 8.2. I recommended nutritional supplementation. Again, I'm a big fan of nutritional supplementation. Things like the DIVFA study. Encourage you to look at the DIVFA study, among others, that supplement patients that have non-proliferative diabetic retinopathy and shows improvements in structure and function and lab testing. This 77-year-old male, how likely are you going to get a 77-year-old male to change their diet? Not going to happen, okay? But you got my left eye, not seeing quite as well. He was amenable to taking up a supplement. When would you see this? Dr. Grant, if you didn't have ERG, when would you see this 77-year-old male whose retina looks darn good, OCTs look pretty good, OCTs look pretty good, without your ERG, when would you have seen this patient back?
Yeah, based on photos and OCT, I'm seeing for an annual comprehensive exam.
Exactly. But the ERG changes that, going, all right, vision's down a little bit, ERG's not normal. Let's see this patient back in 6 months, and maybe 6 months after that. Now you're billing another evaluate, E&M code. Maybe you're doing more regular OCTs, repeat the ERG because we have an abnormal ERG. And again, he didn't change his A1C. He didn't change his diet. 1 year later, I'm going to go back. This was his ERG on the first visit. And 2 visits later, 1 year later, this was his ERG. And look at the qualitative difference. Ignore the number, even though that's the most important, I think, is the number. But ignore the number in this case and just look at the waveforms. Look at those qualitative waveforms from this to that. Significantly improved. Again, he took the supplement. A1C was not changed, but we are moving things in the right direction. He was thrilled. Guess what his visual acuity was? It was 20/30 plus, and it was 20/30 plus a year later. But that number that Dr. Grant mentioned, he was happy that his number was improving, his EKG for the back of the eye was improving, and this is a very, very happy patient that we are caring for him in the best possible manner there. So, Dr. Grant, take us home in our last 5 minutes. Glaucoma.
Absolutely, yeah. So we'll talk about a case that includes glaucoma, diabetes, and hypertensive in under 4 minutes. We're gonna go quick. So this is, I think it's a great case just because it really highlights, I think, a question that most of us have in clinical practice. We're sitting on the fence of glaucoma suspect patient of treat or not to treat, right? I think that's probably the most common example of that, treat or not to treat. This is a 59-year-old Caucasian female. Basically, history, she does have coexisting diabetic retinopathy, hypertensive retinopathy, labeled as a glaucoma suspect based on mainly high IOPs, corneal corrected IOPs 22 and 24, does have thick corneas, and so those are inflated a little bit, but on your usual suspects in terms of medications, high blood pressure, high cholesterol, diabetes. Fundus photos, if you can see them, they're zoomed out a little bit. Basically, she does have, scattered dot blot hemorrhages. Actually, it's more suggestive of hypertensive changes than diabetic changes, just based on the location being a little bit more peripheral. Looking at the optic nerves, the next slide zooms in on the optic nerves. And again, if I'm just looking at these optic nerves, we can go to the next one there, Dr. Myers. Again, nothing stands out to me tremendously on the optic nerve from a cupping standpoint. If I'm convincing myself, maybe a little bit of pallor on that right side. But again, not your massive, 0.8 with a significant bean potting cup. Visual fields a little bit non-specific as well, a little bit worse on the right eye than the left eye, but not your classic early nasal step or anything on the inferior side associated with the right eye. Actually have GCC testing and OCTA testing of the nerve, all of it kind of pointing toward this non-specific anatomical structural findings being a little bit worse in the right than the left. Now, some of us may at this point in time say, yeah, that's enough structural testing to have me treat them. Again, still kind of on the fence because she does have thick corneas. If we go to the next slide here. The visual field polar analysis with some of the equipment that was used didn't show the consistency of field defects matching structural changes. And I think we see that a lot. Again, visual field testing is subjective, not objective. And so it requires patient input, patient influence. And so sometimes it can be misleading. Go to the next slide here. It's an OCT of the foveal avascular zone in the central retina. Again, this patient is diabetic. A little bit of asymmetry in the foveal avascular zone, nothing really mind-blowing there or game-changing there. We did OCTA as well, just to look at the angle based on the high ocular pressure. I think that's the next slide.
Well, and Dr. Grant, I would just say here, this is how your tests feed each other. Like when I know this is a glaucoma case, when I see this OCTA showing asymmetry of the FAZ, that is a reason to run a DR protocol right then and there. We're focusing on glaucoma here, right, but go back to that diabetes and diabetic retinopathy. You now have a billable code that you can do our diabetic retinopathy protocol as well if this patient didn't have glaucoma.
Right, correct. So OCT of the angles here, a little bit narrow, nothing major. They're not closed. So we get to the ERG, and this is a different protocol than Dr. Lighthizer had been showing on the DR score. What I like about this protocol is it's a little bit more in terms of the specificity of where that damage is maybe coming from. So the other protocols give you a global assessment in terms of your speed and your strength, what we call latency and amplitude. This actually teases it out to different parts of the retina. That first, I'm going to use some optometry school codes or words here. The first deep polarization is the A wave, which is that kind of jut down a little bit. That's your photoreceptor layer in both eyes. Then we've got a repolarization. That's your B wave, which is your bipolar cells, your communicating cells. And the part that we're looking for most specifically here from an optic nerve pathology is that last one. It's the PHNR, which is the ganglion cell complex. And there's a little dot at the very right side of that box. And that's actually where the additional depolarization reached a critical level, basically saying this response from the ganglion cell complex is too slow. It's too slow. There's damage to the cells. There's not enough strength or speed to that signal. And so even though in this case we could do a flicker 16 and it might be a little bit slow, but this protocol actually teases it out and it says, you know what, photoreceptor layers within normal, bipolar cell layers within normal, but the ganglion cell complex is stressed and it's showing a delayed response. And it's also showing some asymmetry right to left, because you can see on the left eye there that that dot falls within the reference range of normal. So this was enough for us to tip the scales and say, look, we have not just anatomical changes, we have confirmed functional changes, not just on non-specific visual field findings, but also on the ERG. And so this patient was referred for SLT. Again, we feel she's going to do fantastic. But on this case, many codes. Really, you could argue every single protocol could be run. She has diabetes. You could do the DR protocol. She has hypertensive retinopathy. You could do the flicker 16 protocol, and the PHNR gives us information. When I'm seeing this patient, I'm most likely seeing this patient about every 4 months based on the glaucoma and the pressure, but I'm going to alternate those. I'm going to get a DR score every year, and I'm also going to get a PHNR score at least once a year so that I can watch those different sensitivity and specificity numbers based on her different levels of pathology.
You know, Dr. Grant, this is one where it was just maybe the right eye is just a little bit more suspicious. The right eye is maybe a little bit more suspicious, and but not ready to pull the trigger just yet. And to have that additional piece of data that agrees with the OCT, the ERG that says, boy, there's some dysfunction right eye more than the left eye. To me, this is really the straw that broke the camel's back, that you're on the fence. How many of you have been on the fence in glaucoma before? Is this glaucoma? Is it not? There is, one way or the other. This is that helps to tip you on one side or the other. In this case, I think this is glaucoma. I look at the W ratio to break this down really quickly when I'm evaluating the photopic negative response. Again, think ganglion cell function. Ganglions, all of you do ganglion cell structure. There's the test right there. Okay, here's your ganglion cell analysis. That is ganglion cell structure. The photopic negative response is ganglion cell function. And I look at the W ratio among other things, but if this number is 11% or lower, that is abnormal. 11% or lower, that is abnormal. The higher the number, the more normal. The lower the number, the more abnormal. So go down, and again, they're both in the normal ranges, but look at the asymmetry with the right eye much lower than the left eye there. So again, Dr. Grant beautifully covered that case, structure and function. So very, very important. Again, it's kind of a chicken or egg. Which one comes before the other? You need both. You guys do structure and function so well. You believe in it based on our first question, and so do Dr. Grant and I as well. So with that, we're going to open it up in our last 5 to 10 minutes for questions. Who's feeding us questions?
So, Dr. Lighthizer, there's a question in here, again, an abbreviation. I don't know. What are considered WNL for each item? A wave, implicit time, amplitude, B wave, PHNR, et cetera. Okay. Thanks, April.
I was actually typing back to that one, but I'll let you guys respond. I'll just erase this.
All right.
What was the question again?
Just what's within normal limits for those values. Again, I don't have them memorized. It's a reference range that's on the printout for each one. So it gives you the reference range, abnormal and normal. So you've got the visual representation of the actual waveform, and then you also have the milliseconds and microvolts in terms of speed and strength, and reference range right next to it, and then the patient's actual performance.
Those fluctuate from patient to patient depending on their age group. So it's always going to be different from test to test depending on the patient's age.
Yep. Age affects it. Each visit affects it. You guys don't get the same OCT measurement on every patient visit after visit. There can be some inter-test fluctuations. Same thing here. Again, it gives you a nice reference range here when you're looking above this for the PHNR. Again, we talked about the W ratio just now. I also look at the B wave time. If that's 89% or higher, that can indicate some stress of that. So it just depends on the test that you're looking at. But we covered the main things to hit. Other questions?
I did see a question come across.
Somebody asked specifically about that. Oh, go ahead, Dr. Grant.
There was a billing question. Can you do OCT and ERG same day? Absolutely, you can. There's really no bundling that you cannot do. And so a couple things. You do not need a modifier to be able to do the test on the same day. You do not need a modifier on the exam code. You do not need a 25 modifier on the E&M visit to be able to do it the same day as your office visit code. You can run it the same day as a visual field. You can run it the same day as an OCT, a fundus photo, gonioscopy. There really is not anything that it can't be coupled with from a coding and billing standpoint. It just has to be diagnosis that is relevant for the ERG tests, which are ample.
And don't forget about your subjective visual complaints of decreased vision, subjective visual complaint, color vision abnormalities, nighttime vision issues. Those are all codes that feed an ERG to try to uncover what's the problem in that particular case. Gail.
Someone asked how this can be used, or how the RETeval can be used in pediatric patients.
So, I mean, it depends on what condition are you looking for, in pediatric patients. Or, if you have a 12-year-old that has abnormal color vision and is very light sensitive, you could certainly run this to try to detect a cone dystrophy. If you have a patient that has unexplained vision loss and you're trying to figure out what's going on, you could run an ERG, and if the ERG comes back normal, that helps to rule out one avenue of potentially causing that. If the ERG comes back abnormal, well, now you're isolating what could be the cause of their decreased vision. So it just depends on the condition. They do have to be able to fixate, not super critically, but if they're moving their eye all over the place, you may not get reliable results. The youngest that I've ever done this in is late in the first decade of life. You could reasonably run this on 8-year-old, 9-year-old, 10-year-old, 11-year-old. I've never run this on a 3-year-old before, or a 1-year-old before, but usually you're not going to need that for diabetic retinopathy, glaucoma, things like that. Dr. Grant, how would you answer that?
Yeah, I would say that the time we might do it on pediatric would be just maybe unexplained decrease in visual acuity. We get a flicker 16 most of the time, just tends to be the fastest protocol. Yeah, I don't think the lowest maybe we've done is 12, like a type 1 diabetic that we just want to get a baseline so that we can track the DR score and watch for progression over time. But most of the bread and butter is not in pediatric patients, but it does have its use for seeing if there's truly a retinal pathology for a healthy looking or generally healthy looking retina, but 20/50, 20/60 vision that you can't fix.
Of note, the test does have a VEP in it. It is the unexplained vision loss, the visual evoked potential. The VEP is really indicated to try to figure out, is this organic vision loss or is this non-organic vision loss? It has a flash ERG. Remember, this is a flash test, a flash ERG. It has a flash VEP in it as well. Typically, the pattern VEP has more utility and more value, but you can use the flash VEP to give you an idea, how's the visual pathway responding to a flash stimulus. So there is a VEP in the RETeval.
And just so you guys know too, as far as like the normative database ranges that we have, that actually does go down to the age of 4. So technically speaking, you can use it if you ever decide that you wanted to, and still get a colorized report.
Yep.
All right, Dr. Lighthizer and Grant, we have NPDR is frequently asymptomatic. Help me understand why the DR score is only one number.
I think it said asymmetric. Is that what they mean? Because I thought.
Oh, I'm sorry. Yeah.
Asymmetric.
I'm sorry.
Ocular. Dr. Lighthizer, I think you might be able to answer this a little bit better, but I think that isn't the DR score formulated from an A wave of one eye, a B wave of the other, and so it's a combination. The score itself is a combination of both eyes. Correct?
That is correct. It's a combination of exactly what you just said. So it's looking at measurements from both eyes. So the number, the DR score, is a compilation of both eyes put together. You are absolutely correct that it is often asymmetric, and that's why I look at that. Let's go back here. It's often asymmetric, and that's why you look at not only this number, which gives you kind of a global picture of where we're at binocular with both eyes together, but I look at the qualitative data here and the qualitative data here, and I dive into these numbers as well. So these are really where you parse out that asymmetry. One is, what is the exact speed in the right eye, and the strength in the right eye, and the speed in the left eye, and the strength in the left eye, looking at the qualitative data in both. You're looking at the pupil response. And again, it summates all of that, adds it kind of together to give you one number that kind of represents the patient overall. But if they have asymmetric disease, you dive down into here, into the numbers, and that's what I'm going to follow over time.
So Nate, a related question. Somebody's like saying, how can you do this on a monocular patient?
Question is, how can you do this in a monocular?
Right. So how does the DR score for a person that only has one eye?
That is a great question, Dr. Grant. I'm trying to think I don't know that I've ever done this in a patient that lost an eye and only had one eye. So I can't comment from that clinically. I would guess that you're not going to get a DR score. Maybe it just defaults to both in one eye. I don't know that.
Yeah.
Dale or April, do you know?
It will still give a score, but it's not going to be obviously as accurate because it's going to be using the responses from the one single eye. So in that type of situation, you can't really compare that normal to like the normative database ranges for normal and abnormal. If anything, you would just kind of use that as a baseline test and let them follow them for progression and let them kind of serve as their own baseline over time.
Yep.
Yeah. In those instances, we've done just a flicker 16 because again, you still have the functional
pretty much
data
the same
in
thing.
terms of latency and amplitude. You can still assess the robustness of the response. It's just you don't have the DR score when it's not bilateral, or an accurate DR score. It's not bilateral.
And Dr. Grant, don't you feel like I start with the DR score to get a kind of big picture, 10,000 foot view, and I always glance at it at the end, but in the middle is really the nuts and bolts of this, of looking at the waveform and looking at all these numbers. That's where you as the doctor are going to get most of your information. Would you agree with that?
I 100%. And again, I know I keep broken record here, equating it to glaucoma. I think the DR score number, it's for us some, but that's the number for the patient to take with them, just like the pressure is, right? But we would never treat exclusively glaucoma based on IOP, right? We want to get all the other tests to make sure that we're digging into the anatomy and the function. Same thing here, right? The DR score is a great easy to understand number for the patient to hopefully influence compliance or follow-up or whatever. And it gives us risk assessment, but the real value comes in evaluating those waveforms and comparing them to normal.
So kind of a related question. It says, what quality of change is considered progression?
It depends, is what that you're going to add up the entire picture of what the retina looks like. What's the OCT? What's the A1C? What's the vision? When I see those percentages, when I see them change by 10 to 15%, that's what I consider to be clinically significant. If it goes from 52 to 56, that's that or 52 to 49, that can be intertest variability. When it changes by, again, 10 to 15% or more, that's 10% is my minimum. That's what I consider clinically significant for these percentages here. For the DR score, again, that's kind of adding up a whole bunch of different things. I'm looking at 1.5 to 2 is what I consider clinically relevant, and it worsening or positively changing with diet, exercise, A1C improvement, nutritional supplementation. If they go from a 21.8 to a 21.3, that's about the same. But if they go from a 21.8 to a 20.1, that's starting to catch my attention. That changed by 1.7. So 1.5 to 2 clinically is in my mind. And again, 10 to 15% for each of these numbers. But that's just me, how I've developed that clinically. Dr. Grant, maybe you do it differently.
I would agree on most cases. We kind of rely some on the Burgell study that showed how a change in DR score affects the risk factor. And I know we didn't dive too much into that 23.5 and the likelihood of retinopathy that needs retinal treatment. But basically, if you have a 3-point increase in your DR score, it's going to double your risk factor. Right. So to me, I consider 3 points to be the kind of that breaking point of really significant. On the other tests, on the PHNR, we have a case that that we're working on right now that, showed progression of about 20 milliseconds on a 6 months removed PHNR. So again, I would say if it's greater than 15% of the number itself, 100% and repeatable, I would count that. But for the DR score, I'm looking baseline. If it's 3 points higher, then I know that that's doubling my risk factor based on the Burkell study. When you get more than 3, then the numbers get kind of goofy bad. But yeah, 3 point is significant to me.
And I don't want them to get to that level. That's why I start at 1.5 to 2. And if we're trending, if it goes 0.4 and then 1.2 and then 1.7 and then 2 point, you're following that over time. So you can jump on that before that risk doubles to that patient.
Yeah.
All right, looks like there's one more question. So it says, to expand on the normative ranges, I noticed the focus on this case to the A wave amplitude at 10% specifically. So I think she's talking about the PHNR. At what percent do you start sensing concern? Is 89% a good percent to be under for all 3 implicit times? Is 11% also a good area to get suspicious for amplitudes of all waves?
Yeah, I don't dive that deep on this one. When I'm looking at the photopic negative response, it is the W ratio, which is what I look at 11% or less being abnormal, the W ratio, and then the B wave latency or implicit time as 89% or higher being abnormal. Again, remember that you don't want a high percentage in the 100-yard dash. You want low percentage. So as this number is creeping up, 89% or abnormal or above is abnormal for the B wave. For the A wave, I would kick that to April or Dr. Grant. I don't. Again, A wave is photoreceptors. That's what the A wave is, from the photoreceptor. So I'm not looking at that in terms of glaucoma, because that's ganglion cells. That's just me. But again, we learn all the time. You guys have any comments on that?
Yeah, I would agree on this one. I'm paying most attention on the PHNR. It does make sense in this case that we would have some outer retinal, because we have outer retinal pathology based on the hypertensive changes and
Yes.
the diabetic changes, that we should see an abnormal A wave and B wave. But if I'm doing this case in a vacuum and I see A wave and B wave reduced, speed and latency, now I'm looking for other retinal reasons why, right? I'm not focusing on glaucoma for that. That's the PHNR. But we already know in this case, and we've already done our due diligence, we have our fundus photography, our OCTs or OCTA. So those make sense to me. But if I hadn't had those, I would be getting the more structural tests to make sure that that makes sense based on reduced A wave and B wave.
Yeah, don't you think the DR protocol, that's really telling me what the A wave and the B wave are telling me from this perspective, right? Or the flicker, that's doing the work for me there, is the flicker or the DR protocol for the A wave and B wave. It's here, but I'm looking at the photopic negative response. That's ganglion cells.
Mm-hmm. And I think too, part of that question is kind of a jumbled question, just because we have different criteria for like different reports that we do. So basically like the DR assessment and the flicker test, and even some of the portions of the PHNR test will still follow like the other ranges for what is normal and abnormal for your amplitude and your implicit time. Whereas the PHNR test is kind of its own, separate type of thing, to where the 2 most important criteria of that is, the B wave millisecond timing and then the W ratio under the PHNR. So I think that question kind of got like, it was like one question for all reports, but the PHNR is a little bit separate because we do have those separate criteria with different numbers for what is normal and abnormal compared to the other protocols.
And then there was one question here. April answered part of it, but I'll let the doctors weigh in. Was what is the average time to perform the test and to interpret the test? So April kind of answered the time to perform the test. If you two want to address the interpretation, that would be.
I think the interpretation of the report is the quickest. I mean, you think of setting up the test, performing the test, and interpreting the test. Once you start doing this, The interpreting the test is the quickest of the three, and they're all quick. Setting up the test takes, I don't know, a minute. Performing the test is going to take you between 45 seconds and a minute and a half per eye of actually performing the test. And then interpreting it is a matter of 30 seconds, if not quicker, once you look at this and go, yep, boom, 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 here we go.
Yeah, I would agree. And one thing I would say is, just to kind of this audience is, don't let maybe the idea of needing to know everything about, retinophysiology and electrophysiology inhibit you from incorporating this type of technology, right? If you can understand enough to say thick retina, stressed retina means slower and weaker response, you already know 200% more than your patients do, right? So, it's a matter of getting the technology into your hands and then looking at, tens and then 20s and then hundreds of these and then starting to recognize the patterns. But don't feel like you have to have a PhD in electrophysiology to be able to interpret these and intelligently talk about these with patients. How the retina works far better than your patients do. You'd be surprised at how well that you could do with this.
Yep.
All right, guys, I think we answered all of the questions in the chat. As I said in the introduction, everybody who registered for the program will receive a recording of it. Because we had some issues with the blurriness of the slides, we will also send you a PDF of the slides so you have them if you want to look at them. Plus, they'll be in the recording. We also will send a copy of the reimbursement and coding guide because there were some questions on reimbursement and coding. All right. I appreciate everyone's time. Dr. Lighthizer, Dr. Grant, for your expertise and for sharing what you know. April, you as well. Have a good night, everyone.
Thanks, everybody. Enjoy your evening.